Hello, students. We are here to talk about the OQE questions for Chapter 6. Again, I tried to clump them together according to category, but there were a lot more questions this time than last, so I'll try to get through them as quick as possible. The first question asks about the term petting. And so petting is a way of being intimate with another person involving engaging in sexually stimulating, caressing, or touching. And so that's kind of a broad definition of it. And so it's just another way to say engaging in some kind of intimate or sexual behavior with the use of touch. Next is asking about females have varied mental and physical stimulation that can lead to orgasm. So why do they have more difficulty experiencing an orgasm than a male? This is kind of a loaded question. Some of it relates to the mental state that an individual may be in when they're engaging in sexual behavior. And so, if a female is thinking about society expectations and norms and religious and parental teachings, media, stereotypes about women who engage in sexual behaviors, and so on, they're likely not to be able to be comfortable enough to actually enjoy and be mindful of what's going on and what's happening in that moment. And so it being in the mind and having these different areas doesn't necessarily translate directly to increased sexual pleasure, ability to reach orgasm. We're also taught that sex equals sexual intercourse, so penis vagina sex. So some cases, those other areas of the female body that could otherwise be stimulated to bring a person to orgasm may be ignored. In preference for that. And so unfortunately it may be a missed opportunity for a woman to be stimulated in other ways. It also takes an average of 20 minutes for a female to go from initially being turned on to orgasm. And so there's many cases where the sexual activity doesn't last quite that long, so it doesn't get to the point where the female can actually have the orgasm. Females are also not encouraged, or at least not normed, to explore their own body and figure out what they enjoy. So in some cases, like the woman might not even be able to let someone know what they enjoy doing, or what parts of their body they want their partner to pay attention to. Males in our society are more encouraged and expected to masturbate, but this could be looked down on in females. The book states that the brain is a primary site for orgasm for women, so the brain may be primary, but it's not the only thing. Why do some women have orgasms when they're being raped if the mind is the main thing? Well, again, there are lots of different areas of the female body that could be stimulated. There are also physical things that happen to a woman that lead to orgasm that can happen during rape. So those specific areas can be stimulated and eventually lead to orgasm. In addition, during rape, there may be other hormonal things happening in the person's body and emotions that they're going through that could potentially lead to that. So some of the emotions leading to hormones or chemicals being released in the body that could lead to an orgasm in a consensual situation might end up also being triggered during a rape situation, unfortunately. And so I'm not by any means explaining this in like sort of proper terms and the biological chemical pieces, but sometimes there are those things that end up leading to this situation. And so when people have the idea that if a woman orgasmed, then it wasn't assault or it wasn't rape, it's just wrong, because there are lots of different factors that can lead to that happening. From your professional opinion, why do females have more concerns than males about the risks associated? Some of this can be related to perceptions in our society, as I've already talked about. Also, if a male, along the lines of that, if a male gets an STI, he is not treated the way a female would be if she were to get an STI. So they could have only had sexual activity with one individual and had an STI, but the woman kind of could be labeled in a certain way, whereas the male may not be in our society. The same thing with pregnancy. The woman literally carries the burden of that. And so they may be concerned about what a pregnancy could mean for them. Let's see what else. Yeah, there's lots of individual factors and things like that that could, you know, lead a person to have more concerns about the consequences associated with sexual activity. But a lot of it maybe has to do with our culture and how we're raised in the environments we live in, things like that. There could be other things that I'm just not thinking of right now as well. I wonder about the rationale for making the criteria for premature ejaculation more stringent. So I do think that it's possible that this diagnosis was given a lot um, more often than it needed to be, that a person might have one situation where they felt like they had premature ejaculation and they were sort of being labeled that way, or felt like it was a little bit faster than they should have or they normally would, and so they kind of end up getting labeled for that. But there's lots of different factors that can lead to that. It could be just anxiety in that moment with that situation, or they have other things on their mind, or whatever. And so just because a person has concerns about that doesn't mean that they need to have that diagnosis and in-depth treatment for that. I mean, it could be dealt with CBT or things like that, or just, again, not even need treatment, just be like a single situation or a handful of situations. And so making the diagnosis a little bit more stringent would cause us to put that onto people less often than what maybe it had been historically. What types of factors account for the cultural differences in men's low sex desire? So some of it could be related to the way different cultures may socialize individuals. It can also be impacted by genetics, environments, and other factors related to culture, location, and beliefs. That's about the extent of my knowledge in this area. Could be something really good to look up and continue to explore if you're interested. So reading chapter 6, I agree that social norms and pressures are a big factor. However, I was a bit confused when it said family expectations and history is also a factor. I understand how family expectations is a factor, but I don't understand what they mean by family history being a factor. So when I hear this statement, what comes to mind for me is an individual knows about their family and may make choices based on that. So for example, if I know that my parents were really young when they had me and they struggled because of having children young, and perhaps, maybe you're raised by a single parent and due to different poor choices in sexual partners, or if someone in the family has a history of issues with STDs and that led to, either infertility or something like that, these factors may impact your decisions to engage in certain sexual behaviors. And so family history, I think, plays a part in that way of like, what circumstances are you aware of, and have you seen experience in your family and that led to you making decisions to do or not to do things. What else did I put down about less stable relationships or sexual infidelity in the family? I may see that as the norm and engage in it, or I may feel like, oh, that was really hurtful to the family, so I'm not going to engage in it. What would it look like to counsel a person who chooses to be celibate but battles sticking to it? This is highly dependent on the reason for celibacy, because you would want to explore that and the meaning of that to them so that they could maybe like clarify their purpose or their goal and identify different ways that could, get rid of any barriers to staying celibate and stuff like that. What are their causes for struggle? What are the reasons that they're struggling with their decision? I think it would be important to help them clarify their values and beliefs, to identify the purpose behind their actions. They may need to find strength in their ultimate goal or in their value system. You could try to support them in the ways that they feel like they need assistance, so kind of identifying those areas, and also encourage them to make decisions that are healthy and make them feel fulfilled, so that they're not making this decision for any other reason than they really feel like it's important and they want to do this. While I was reading the section of celibacy and paraphilias, I asked myself how often religious leaders come to therapy. As a sex counselor, how would you work with a priest or religious leader that's celibate but has developed strong sexual feelings for someone? Would a counselor focus on the celibacy, normalizing his desires of both. Again, it would be really highly dependent on the other circumstances involved. Counseling could focus on all of those things that you listed. The client would also have to determine what they feel more strongly about, staying true to their vow or finding appropriate ways to express their sexual energy. In the case where celibacy means no sex and no masturbation, it's a bit challenging for me, I admit, because that gives little options in how to express their sexual energy. And so they'd kind of have to maybe find other ways to engage in things like, I don't know, hobbies or sports or things like that to kind of take away some of that energy and let it out in that way. For me personally, I feel like we all are sexual beings, and that our natural sex drive, when it's being blocked by something like that, it could start to come out in unhealthy and harmful ways. And so it's something to really watch out for and be careful for. Would it be appropriate to ask a client why they're engaging in celibacy? And I think it really depends on the situation. I think in most cases it would be appropriate to ask, because that could have a big impact on your treatment with them. But if it's not related to what you're working on with them, then I would say that would be something that shouldn't necessarily be asked, because it would be more for your own curiosity or need to know, rather than in an effort to help the client and better understand them in their world. So I don't think it's a bad question to ask. In many cases, it might be a really great question to ask and something like an area to explore, but just make sure that that's why you're asking it, and not just because you're curious to find out why they're choosing celibacy. Does celibacy mean abstaining from self-pleasure? It depends on who's defining it. In some cases, the individual may choose to be celibate from all sexual activity, including self-pleasure. In other situations, they choose to be celibate from engaging in activities with other people, but not necessarily themselves. This one is confusion about how the book defines celibacy as being permanently single across a lifespan, whereas looking it up on Google, it says the state of abstaining from marriage and sexual relations. What's correct? And so again, it depends on who's defining it. The word celibate itself comes from a Latin word meaning unmarried, because traditionally unmarried people would not be having sexual activity, or supposedly, I guess, according to them. And so saying they're celibate means they're unmarried, therefore not engaging in sexual activity with another person. And so I think that that's kind of where that definition of like abstaining from marriage comes from. But a person theoretically could be married and not engage in sexual relations, or they could be not married and engage in it. So again, it's depending on who's defining it. But the word celibacy is used more commonly for someone who's refraining from sexual activity versus someone who is unmarried, because again, they could be unmarried and engaging in sexual activity, so they wouldn't necessarily be celibate. How would a counselor deal with a client who is celibate and feeling pressure from their partner? So one thing is to clarify their values of, being celibate, and also their relationship and what that means to them. Doing couples work, I think, could be a really good way to help them work on their communication with each other and make decisions together about, what behaviors they're going to engage in or not engage in, and if they decide they want to work on these differences, or if they decide they want to uncouple. You have to kind of focus on helping the client make the decision, obviously not kind of making the decision for them or anything, or pushing them towards something, but helping them to clarify, what choices they need to make. The distinction between celibacy and abstinence. Celibacy is being single across the lifespan, whereas abstinence refers to not engaging in sex, anal, vaginal, oral, for a period of time. I always thought of abstinence in terms of something people may do prior to marriage, but not after they've had a sexual experience. I'm curious about how frequently, if at all, it may happen that people choose it for long periods of time, and what are some other reasons other than medical procedures and health-related causes. There could be many reasons for someone to do it. Maybe they're changing their religion, and their religion that they've now found says like not to engage in those behaviors for marriage, and maybe they've engaged in them before and now they stop. It could be for like you said, medical type reasons or physical health reasons, like, oh, if I abstain for this length of time, it makes me more athletically, I don't know, whatever, for a meet or a match or a game or whatever. It could be for spiritual reasons, like they abstain for a while to feel closer to God or to focus on meditation or whatever the circumstance may be. I'm definitely open to anyone else who has ideas about this, because that's about what I came up with. But I'm sure that there could be lots of different reasons for it. I'm not sure if this is a weird question to ask, but I wonder if celibacy or abstinence could lead to other mental health issues. So this is a great question. I wonder if individuals who choose to be celibate or abstinent don't put those sexual urges or energy into something positive, that it could become something negative for them. In my work with sexual offenders specifically, especially with juveniles, I was able to see that if their sexual energy was manifest, or their sexual energy did manifest in unhealthy ways when it was blocked from coming out in healthier, more progressive ways. And so I could see how it could become unhealthy, especially like subconsciously, or even, lead to some kind of paraphilia or things like that potentially. But I don't think that it necessarily has that impact unless it's, pretty significant. And it's not to say that being abstinent or celibate couldn't be done in a healthy and intentional way that doesn't cause harm, or a negative experience, but also promotes a very positive experience in the person. And so I think that there's definitely two ways about it. According to the text, abstinence is used for the choice of not engaging in oral, vaginal, or anal sex for a period of time. What about other ways to reach orgasm? So as stated above with masturbation, it's possible that an individual may choose to not engage in any sexual activity or anything like that that would bring them to orgasm. However, there are other people who would define that as, vaginal, oral, anal sex, and say that any other behavior is okay. So it really depends on the person's definition of it. And how they, want to see it. Are there any characteristics that an individual may show to determine whether they will choose abstinence or celibacy if they were ever diagnosed with HIV? I'm not exactly sure what this question is asking. Who knows what someone's decision might be if something like that happened. In most cases we can say, oh, if this ever happened, I would do this, but we don't really know until that situation happens. So unfortunately, it's kind of hard to say. Has there been research on how various paraphilic disorders develop? Can there be evidence of trauma or other related negative experiences? So there's a lot of research actually being done in this area, that has been done or is currently being done. And there are many factors that can impact the development of a paraphilic disorder. They can vary from person to person or situation to situation. But you will learn a lot more about this when you all do your paraphilic disorder presentations. And so I don't want to go into it too much here. Next question, basically the same. How does a paraphilic disorder develop? In the simplest terms, it's when sexual energy is aimed at a specific object, behavior, type of person, or something like that in an unhealthy manner. But we'll learn about that a little bit more later in the semester. If a client reveals they have sexual interest and arousal in prepubescent children, as a counselor, do you report it? What are the proper steps? So we report suspected abuse or intent to abuse. So if a client specifically says, like, I'm having these feelings about this specific person or these specific people, and I'm kind of working on a plan, or I'm at risk because I'm around, this age and gender or whatever often, I have access, privacy, I have trust, all of these things, then you could potentially disclose it and make a report. But if the client discloses that they have those thoughts and feelings, but they don't want to act on it, and the reason that they're talking about it is because they want help and they don't want to harm anybody, then you wouldn't necessarily report that, because no crime has been committed, and you can potentially help the client to take measures to keep them away from children or vulnerable people, and help them develop other coping skills and stuff like that. So you want to look at, do they have an intent, plan, access, and so on. If you felt that this was out of your scope of practice, then you can definitely refer to another person to work on with them. Or you can see if it's something that feels like a fit to continue to work on with the client. Are all rapists diagnosed with Frederick disorder? I was wondering, and then the second question, I was wondering if rapists would be classified as having this disorder. So no, not necessarily, because someone who is a rapist does not necessarily fit criteria for Frederick disorder. I spelled it wrong there. And someone who fits the criteria for that disorder would not necessarily go out and commit a rape. So it just depends. A person could be both, but they could definitely be one or the other. And so this disorder is when an individual achieves sexual pleasure from rubbing against unsuspecting individuals. So a lot of times this will happen on like crowded buses or subways, where they will start to like rub themselves on an individual and sort of have the cover of, oh, it's a crowded train and that's why we're physically touching, and you know, the bumpiness and the motion of the car is making me kind of move, things like that. And so this is seen as, you know, a really separate behavior. But again, we'll learn a little bit more about this disorder towards the end of the semester. Next question is about bipolar clients having the depressive and manic phases. How would a sex counselor deal with a client who will engage in risky behaviors one day and lacks, you know, complete interest in sex in another day? This can be tricky. Typically, you know, even kind of sexual behaviors aside, with clients who have this kind of cycling, especially like large periods of cycling and things like that, you want to have them kind of keep track of like hours, days, weeks, months, depending on how long their cycles last, and help them to figure out sort of a pattern of it, or if there are triggers of it and things like that, so that they then could engage in different kinds of coping skills for those times. And so you would work on that with the client once you develop, well, you can start working on it before then, but once they develop a pattern and start to be able to predict to some extent where their moods are, you can kind of help them to figure that out. If a client has been previously diagnosed with a mood disorder, has taken medications, should the counselor be in contact with the psychiatrist to discuss the side effects? Absolutely. If you are seeing a client who's also seeing a psychiatrist, some other therapist for a special, like a specialist, like a sex therapist or something, or if they're seeing a primary care doctor for psychotropic medications or anything like that, you want to ask the client for a consent to communicate. They may not give it to you, and in that case, if you feel like it's really necessary, you can tell the client that you're not willing to work with them unless they sign the consent for this provider. But in most cases, I've found clients are very willing to sign consents for these different providers so that you can have communication. If a medication is used to treat mood disorders, such as mood stabilizers, antidepressants, have negative side effects on sexual functioning, for clients who are diagnosed with bipolar mood disorders that are supposed to be taking these medications for a long time, how can sexual issues be resolved then with therapy? So some of it could be helping the client identify ways that they can get themselves turned on, or partners can do it for them. So like, in spite of the medication side effects, what are things that still can kind of help get the process going? And it could be, you know, a little bit more elaborate than, you know, what they are used to when they're not on medication. So it might take a little bit of work and exploration. They may also need to work on some CBT techniques to help with any thinking or behaviors that might prevent them from being more open to things, or doing, you know, things that help them get turned on, or, you know, just their cognitions about taking medication or the effects it's having on them. What is that doing? Is that creating this sort of negativity, which is preventing them from working on it? Also, in some cases, medications can be weaned down, and they can utilize their counseling strategies. So while they're on medication, or even the higher dose of medication, you help them work on those coping strategies so that the medication eventually can be tapered down, and they utilize those more and more often. In addition, you know, when someone starts taking medication, there may be a difference due to the medication. However, there are some habits that the client may have developed that still need to be changed, because they may have been initially a result of the disorder or whatever, but over time they became something that the client is used to doing, and so you can work on changing those as well. Because anxiety disorders cause an increase in alertness, would that be one of the reasons for individuals to feel the need to drink before sex. Possibly, it may help them to be in less of an alert state and kind of worry about things and stuff like that. And they can just kind of focus on what they're doing, which is the sexual activity. Alcohol is a depressant, again, so it kind of decreases that alert state. Ironically, however, the use of alcohol can actually cause sexual issues when someone is under the influence. So they could have delayed ejaculation, inability to obtain or maintain an erection, inability to orgasm, and so on. So it can be tough if someone's taking this to decrease their anxiety, and then it ends up leading into other issues. It was surprising to learn that low levels of anxiety can improve sexual arousal through increased blood flow volume to the genital areas and increased alertness. I always thought that a high level of anxiety would lead to sexual problems, would decrease sexual arousal. The text also mentions that higher levels of anxiety can lead to sexual problems. Where's the line drawn between low and high levels? How are they defined? It can be really difficult to identify where the line gets drawn. A lot of it will have to be kind of you talking to your clients about their experiences, because the line may be very different from one person to the next. One thing that could be a factor is that anxiety has the ability to drive us and motivate us toward or away from things. And so with a low amount of anxiety, the excitement might build. You might have that excitement phase that helps make the experience more pleasurable. But then when the anxiety rises too high, they lose focus on that. I'm not sure I understand the relationship between anxiety, blood flow to the genital regions, pain, and sexual arousal. Similar question to what was just asked. It can help up to a point and then make things more difficult. Would medication with cannabis be a treatment option for hypersexuality and understanding state laws and things like that? Cannabis can be a valid treatment option for a number of different mental health issues, and this one is included. With laws changing, it may be utilized and studied a bit more so that we can learn more about the effects of it and what it can be helpful for. So we'll see as time progresses. How would you best assist a client that suggests that they might have a sex addiction? So if the client does not see this as an issue, you're going to likely have to use some level of motivational interviewing to help move the client into the action stage of change. So if you think of the behavioral stages of change, which you may not have learned yet, and I recognize that, is it starts off with someone who really doesn't recognize that the thing is an issue. They start to recognize there's some issue, but not exactly what it is. Then they start to recognize the thing is an issue. Then they start to prepare to work on it. They engage in working on it, and then they maintain those behaviors. And so motivational interviewing is a technique that helps people to kind of move through those stages so that they recognize this is what is causing some of my issues. If I work on it and change it or do something with it, I'll be in a better place to make better decisions and things like that. And so it's pretty common in treatment with addictions, and so that definitely can be used. When you have that buy-in from a client, it can sometimes help the treatment be more successful because they're more willing to work on things and stuff like that. You could suggest a period of abstinence, but you don't have to, because really what it's about is engaging in sexual activity in healthy ways and not engaging when it's unhealthy. So, if you can only engage in sexual activity that's unhealthy, then maybe a period of abstinence is important so that you can start to learn to engage in it in a healthy way. But other than that, you could just kind of have them separate between what is healthy sexual behaviors and what's unhealthy, and how can they make sure that they're engaging in the healthy forms, not the unhealthy forms. Reading about the squeeze technique used to treat premature ejaculations made me curious if it ever worked. And obviously medications are being used more now. So it had some success, which was why it was used in the first place. I'm not sure if it's not being used as often because it wasn't as effective, or if people are just turning to medications because it's sort of like the quicker fix. I'm not sure. There are definitely studies out there that you could look up statistics and see what they are. But obviously it had some level of success because it was being used. Is there a Gestalt-like approach to working with clients who want to address sexual abuse and rape? So Gestalt is not my primary theoretical orientation. So I admit that I come up a little bit short in answering this question in that way. But I also think about, using techniques where you have the client kind of talk to different parts of themselves and respond as different parts of themselves. And you can, I feel like you could do that with sexual trauma or child abuse. Like talk to your 7-year-old self, talk to this part of yourself that's angry about the abuse, talk to the part of yourself that's sad, and things like that. And so I definitely think that there are lots of different options within Gestalt that could be really effective. Or Gestalt. I always am unsure of how to say the name. Regarding sexual trauma or sexual abuse, would a referral be the best option treatment? Seeing how I'm currently inexperienced in this area, I wouldn't want my client thinking I'm dismissing them, but I don't want to do more harm than good. So, in general, as a therapist, we should all be equipped to work with clients who have levels of trauma, including sexual assault. And so if you feel like you're not as well prepared at this point, that's pretty normal. What you want to do during your internship during school, as well as your licensure internship, is to try to gain some experience while you're under supervision so that you could work with someone who can help to teach you and guide you. You can even ask if you can sit in on sessions with clients who have those issues, if the clients are willing to let you, stuff like that. There are therapists who are trained in specific techniques that work really well for like complex trauma and stuff like that, including EMDR. So you could get trained in something like that, or you could just get, a lot of continuing education and trainings and professional development that revolve around counseling sexual abuse survivors and survivors of childhood sexual abuse, so that you can feel more equipped to work with these clients. In general, almost any client that we're going to be working with, I mean, really people in general, all have had something traumatic, whether it's a loss or, some kind of abusive situation or neglect or whatever. And so to some extent, everyone has their stuff. And so it may not always be, sexual trauma or sexual abuse, but we should be prepared in general to work with, different areas of trauma, and in general as a clinician. Okay. Experience of rape, incest, sexual abuse, molestation, sexual harassment, unwanted sexual experiences, all grouped under the umbrella of sexual trauma. Are there some distinct effects of each on individuals, and can different experiences of abuse affect people in similar ways, no matter the degree, frequency, or relation to the person involved? So yes. It's complicated because there will be differing factors depending on the type of abuse. But that also involves the degree, frequency, and relation of the person involved. However, there are some things that do cut across the board where you'll see them pretty common in anyone, regardless of the type of abuse. And so, again, as many of these questions, it depends on many things. You can imagine that different types of trauma would impact us in different ways. There are some factors that can have an impact of abuse, including relationship with the perpetrator, the amount of times it occurs, the age of the victim, the amount of support around the victim, the extent of abuse, and so on, as different factors. According to the chapter, when it comes to the quality of previous sexual experience, sexual trauma, and future sexual activities, there is no uniform response for people with a history of sexual trauma. In other words, some people who experience sexual trauma engage in less sexual activity after the trauma, whereas others, this is not the case. I imagine the future sexual activity after being a victim of sexual trauma is influenced by a myriad of factors, and wonder whether the factor that has the greatest impact is whether the person received appropriate care, whether it's health care or mental health care related to alleviate the impact of the trauma on physical, cognitive, affective, and behavioral domains of their life. So without psychotherapy, is their likelihood of resuming their sexual life severely limited? Again, this could be the case, but it may not be. There may be so much support and resiliency factors in that person's life that they don't necessarily necessitate psychotherapy. They're able to kind of manage some of it on their own. However, there might be other people where there might be some issues that kind of surface later and not initially. And so if treatment's not sought. So treatment might be sought, way later, years after, because something sort of triggers it or brings it back up. And so what treatment is necessary is really variable. Does someone need more extensive, lengthy treatment, special techniques like EMDR, things like that? Or is someone, pretty good with doing a couple months of CBT and mindfulness and processing their hurts, and they can move on in a little bit of a better way. So it's very, very variable. What are things to look out for, be aware of if you have a client who may be the victim of rape? Do male and female individuals share similar behaviors? So there are so many individual variables that it's really hard to say, because this is dependent on gender, age, support, type of assault, relationship to the victim, and so on. So some things may be having difficulty going to certain places, either the location of where the assault happened or locations that are similar to that, sleeping, nightmares, being alone. Certain times of the day can be triggering, and so on. So you just may see a lot of different factors, but they may not be present in everyone. What are some common long-term impacts of sexual trauma on a client's sexual attitudes? Some things could be sexual promiscuity or sexual anorexia. It can lead to issues with vaginismus, or difficulty with obtaining or maintaining an erection. It really depends on the type of assault and the client's individual response to the assault. People who have experienced past sexual trauma would not be expected to engage in or less frequently engage in sexual activities. I wonder what the ratio is to people who become promiscuous to people who don't engage in sexual activities. So I'm kind of unaware of the numbers or percentages specifically, but there has been a great deal of research done in this area, so you can definitely look those up. Both of these things are possible directions for an individual to go after an assault occurs. Excuse me. But you also want to kind of notice any differences when it comes to frequency of sexual activity. So, after, before the assault happened versus after, are you noticing differences in either direction? And pay attention to that and see if that is one of the impacts. For a child who has experienced sexual assault, immediate therapy would be beneficial. However, child sexual assault can affect an individual's mental health, social effects, and even physical effects. Would this child need continuous intervention throughout their life to prevent these? Not necessarily. Sometimes you can work on some of the initial stuff going on, and then at different stages of the client's life, when they first get into a relationship or decide to have consensual sexual activity, or they decide to have children or whatever, these could be different trigger situations, and so they may come back into counseling to deal with those specifically. And so it's not to say that they would need it ongoing, or even they may not even come back. They may do pretty well and move on in a relatively okay fashion, or even a great fashion. So it really depends on the individual and what happens in their life as they move forward. How do we treat a client that was molested, raped by a member of the same sex when younger, and also identifies as gay, lesbian, but believes that they identify in that way as a result of the abuse and feel uncomfortable with their sexuality? This is really a difficult one. The client may feel that they are attracted to or shy away from members of a certain gender due to their assault. But in reality, they may have always been attracted to that gender or not attracted to that gender. They just express it a little bit more so after an assault occurs. So, for example, an individual may have been attracted to, any gender, both genders, but after an assault happens with a member of the same gender, they may find themselves more attracted to that gender or less attracted to that gender, and so on. It may be helpful to do some psychoeducation with the client to help them to understand different things. Also, remember that sexual behavior is a result of choice, but not necessarily the attraction. So maybe they're engaging in that sexual behavior because of their assault, but maybe they actually are romantically and affectionately attracted to a different gender than they're engaging in activity with. And so it's definitely something to explore and kind of process out with the client. The other thing that I noted is that I would definitely explore what their sexual identity means to them and how comfortable they feel with it, and what people around them, like, are they picking up things that they've been taught, internalized homophobia or things like that. I was interested to read about the relationship between sexuality and substance use. In many cultures, such as the LGBT community, there's a widespread use of substances which are promoted as increasing pleasure. What are some interventions to help clients distinguish between the negative effects of substances on their physical and sexual health? So some of this can be psychoeducation. You can also use motivational interviewing to help them move from, like, okay, there's a problem, but this is not it, to recognizing that that is a problem, if in the case that it is a problem. At times, they may also be using as a result of, like, stigma and internalized homophobia. So that's definitely something to explore, or even rejection from other individuals that lead to the abuse of substances. They may feel like, I can't engage in this behavior unless I'm under the influence of something, because all of these things kind of swirl through my mind, and don't allow me to relax and enjoy it. Final question is, what are some examples of post-traumatic growth? How do they relate to sexuality? So I actually went to a website and quoted this directly, just kind of copied it from there in pieces, you'll see. But so traumatic growth, it's growth that happens after suffering some kind of trauma or distress. And so it's a specific kind of shift in understanding about the world, yourself, or whatever, that isn't like returning to normal after the event, but kind of moving to a richer, deeper understanding after the event. And so that place might likely have not occurred unless the trauma happened, which is really hard to see, because, traumas are things that we wouldn't want to wish upon ourselves or anyone else. But sometimes that post-traumatic growth can occur. And so it's hard, I didn't want that thing to happen, but I also recognize some of the ways that I've grown and stuff like that because of it or from it. And so there's lots of research going on with this, but some of the things that this website that I've linked they identified 5 areas that tend to demonstrate that growth has taken place in this way. So a sense that new opportunities have emerged because of the struggle, a change in relationship with others, such as a deeper personal connection with loved ones or anyone who's suffering, an increased sense of one's personal strength, and resiliency, that I was able to make it through this and come out the other side, a greater appreciation for life in general, deepening of spiritual life, or significant change in one's belief system. And so some examples of this is, we lose a loved one very suddenly, and that brings us closer to other family members or friends that, are also suffering. It could be that you had a near death experience, and you start to appreciate life and enjoy it much more so than you ever did before. It could be that you have this experience that makes you feel closer to some spiritual being, and you start to actually change your belief system and your views on religion and life's meaning because of that. New opportunities that have emerged. So this could be like, there was a situation where this person's child, I believe, was killed by this other young man, and the father actually sought out, I believe, the grandfather of the murderer, and the two of them worked together to educate people on forgiveness and moving forward, and helping others that are struggling, and all kinds of wonderful things. And so they would never have had that opportunity to work together and create programming and education and go around and do speaking events had that traumatic loss not occurred for both parties. And that's one of the big things about it, is that I lost a son to death, but you lost this child or grandchild because they're incarcerated, and how that actually could bring people together. So there's lots of different potential ways that this could sort of show itself. And so I have that listed on there. It also brings up to remember that post-traumatic growth is different than resilience. Resilience helps you to bounce back after a crisis, whereas post-traumatic growth is actually a change that alters a person's perception of life in some way. So it's a little bit different. So that is it. I obviously have attached the document here for you guys to look at, and you will see me again when we come back for the OQEs for Chapter 7. Thank you.